My speech will be about respiratory compromise and how we come up with the idea of this trial. And I will also try to set the ground a bit for my colleagues, which will present some of the different pieces of Prodigy together with you. Hopefully we will end up with a very nice discussion. I have some financial disclosures mainly related to the Prodigy trial, so my department gets some money to include patients for that. And moreover, my work is more or less dedicated to perioperative outcome research, and therefore I have also to declare some conflicts. This slide is important. This slide is the hospital standardized mortality rate of the Netherlands, a small country. And as you can see here, this is our own hospital. I have chosen a good year. And this is one number we get every year in the range of September. And the hospital directors are not sleeping well the days before, because this is quite an important number. And there are two things which are important. First of all, the hospital standardized mortality is mainly driven by surgical care. Cardiology, infectiology, oncology sometimes have an impact, but the main factor describing hospitals' standardized mortality rate is surgical mortality, and mainly in the post-operative period. When we look how we are doing, our colleagues from cardiology are doing fine. They are better each year. This is data comparing the numbers from 2005 to 2011, where it is nicely shown that the mortality around myocardial infarction and heart failure decreases a bit. When you look at the surgical data, there's no improvement. Probably it's either the other way around, and there are numerous explanations of that, like the number of older people undergoing surgery, bigger procedures, etc. And by the way, a so-called simple, easy to diagnose complication like postoperative pneumonia is also not doing better. So when we look at the global volume of surgery, some data we see, and that's what we are all proud of, Paolo Pelosi talked about it also yesterday, we were able to reduce the, let's say, intraoperative anesthesia-related mortality quite substantial. We were not able to reduce the perioperative mortality within, let's say, the first 30 days after surgery. In other words, we have to deal with severe complications which do not necessarily take place in the operating theater or in the post-anesthesia care unit or the surgical ICU, but probably a bit later in the process. The big question is, and I put the whole definition here on this slide, what means failure to rescue? And what a lot of studies have been shown, which were done during the last 10 to 15 years, is that we still have wide variations in surgical mortality, post-operatively, and we are not pretty sure if this is related to complications, because complications occur all the time, but if this is related to the fact that we are not able to identify the complications in an adequate amount of time and have enough time to react appropriately. Most of you know these situations on a surgical ward where approximately 30 to 40 patients are there and 2 to 3 nurses are there on the night shift, and they all have to deal with an enormous amount of patients and also with an enormous amount of complications. Failure to rescue means, in fact, preventable mortality, which probably have some impact on the overall numbers we get. A couple of years ago, we started to look at this phenomenon in Europe. We initiated a trial, the so-called USOS trial, initiated by the European Society of Anesthesiology and the European Society of Intensive Care Medicine, and we were interested about the mortality in Europe. Just simple, 7 days, straightforward trial, pragmatic. And we found that there's a huge difference, and we can discuss the numbers quite intense if this is really the reflection. And the other thing, that's the reason why we decided to do this trial together with the European Society of Intensive Care. We would like to know if it helps if we send our patients to the intensive care unit after surgery. And this was the second main finding. As you can see here, countries like Sweden, Norway, Iceland, etc., they do quite well, but they don't send a lot of patients to the intensive care unit. In other words, one of the primary findings of this trial was patients die on the normal ward. Sometimes they go back to the ICU after having contact with a reanimation team or a rapid response team. But basically, we have some issues which are primarily related to our care at the normal ward. We then combined the data from Europe, did a new trial, combined it with data from the rest of the world, and basically we found the same number, that we have a certain amount of patients which we do not identify, which get into trouble, and we cannot detect the complication in an appropriate time frame. So the basic findings is, which we also studied was, okay, safe surgery checklists are good for the patient. Admission to the ICU in the common sense is not able to reduce mortality. There's probably technology on the ward needed to get a better insight into the patient and to identify patients at risk earlier, and there needs to be somebody who can react on that. That means you need a new paradigm of monitoring for the patients in the postoperative period after surgery. It's a topic which is described in anesthesia as perioperative medicine bringing to a newer level. We need to know which patients should be monitored because it's an enormous approach to get that done. And we need to find out what are the seminal complications which after surgery can lead to all the consequences which ultimately results in mortality. Probably respiratory depression is one of these sentinel complications. This is an editorial written by Dan Sessler after a publication in anesthesiology in March 2015, which identified a couple of closed claims related to respiratory depression. Luca Brassi will discuss this topic in more depth. So, in another editorial, it is probably a new paradigm. The vulnerable patient, respiratory depression, and as we can see, that's the reason ultimately why we decided to do Prodigy, because we had a lot of data from observational trials, and at a certain time point we were very much interested to figure out, can we predict respiratory depression? Is it related to the use of pain therapeutics, in particular opioids? And in a second stage, is it possible to develop strategies probably to prevent it? That's the, let's say, the playground for Prodigy. Why we are interested in opioid therapy? Because it's a common phenomenon. We all heard about the issues with respect to opioid use, in particular in the United States, probably also in the UK. We heard less of these topics from continental Europe, but our databases are far from complete. So we were interested, is opioid therapy in the surgical and the non-surgical patient related to respiratory depression? Can we figure out if there's something like a prediction tool? We did Prodigy both in the US, in Asia, and in Europe to find out, are patients different, is the pre-operative therapy different, etc. This is something we will discuss in the talk of Richard Ehrman. Last but not least, this slide figures out, let's say, a summary. Nearly half of all in-hospital cardiorespiratory arrests occur on the general ward. If this happens, mortality is 1,000 times higher. And one cause of mortality, opioid-induced adverse events, was judged in the closed claims to be highly preventable, because this is something we are initiating. We can work on that. If opioid-induced respiratory depression occurs, it results in length of stay, much longer, higher readmission rate, and costs. And that's the other story we have to face. I know the wards where 3 pulse oximeters are available for all of these 40 patients, and on the beginning of each shift, the nurses decide, okay, which patients needs that technology most. But it's probably not the way to go. We are a bit more far in technology. Well, basically, Prodigy was designed from clinicians interested in that field to figure out, is there be a simple tool to stratify patients at risk? And second, is there any possibility to derive something like a risk score to help us judge clinically which patient needs which part of care? Who could benefit from monitoring? So, and now the floor is up to Luca to go a bit further in this topic. Thank you.